Dr. O'Leary is going to be coming up first. She's going to be joining us here in just a couple of minutes. And so I forgot I was supposed to tell her to sign on. It's okay. So anyhow, she's our movement disorder specialist at our Providence St. Vincent location, and she does an amazing job. She has a huge, huge following there, and she really does amazing work for those with Parkinson's. Somebody's got their audio on. Maybe we check and mute ourselves if you don't mind, please. Following that, we're going to have Lauren McIntyre. She is our lead physical therapist at our rehab outpatient facility, and she does amazing work, both helping with myself and my support groups, our events, as well as with Brian Grant Foundation. She's done a lot of different types of work in regards to helping patients with Parkinson's. Deb Volkerson, she is an occupational therapist located out of our Providence rehab facility across the street from the hospital on 47th and Gleason. And she knows a lot, and she's going to be able to really help with those, activities of daily living and other kinds of things that, we just don't think about. Occupational therapists are amazing. And so we're going to have her share with us at the end. And then I'll close by thanking you so much for coming.
All right, I'm going to talk about mid-stage to advanced Parkinson's disease. I am Joanna O'Leary. I'm a movement disorder neurologist, and as Teresa said, I work here at St. Vincent's, and I probably know a bunch of you. And we'll see. Oops, sorry. We're just gonna talk about everything I know. So, okay. I know this is not kind of like talking about mid to advanced stage Parkinson's in this part, but it's good to know exactly what Parkinson's is. So it's a neurodegenerative disorder. And when I say that, it affects your nerves and it gets worse over time. We don't really know how it starts, but we do know that when it does occur, that basically normal proteins that we have in our nerve cells, I don't know exactly how it starts, but we do know that normal proteins in your nerve cells get misfolded, and when they misfold, they clump together into insoluble masses that can't be broken down by the nerve cells. Those insoluble masses are called Lewy bodies. And the disposal system of the nerve cell gets gummed up with these Lewy bodies, and the nerve cells die. And then other nerve cells kind of in the surrounding area start becoming affected as well. So it starts in one area and then starts affecting more and more nerve cells over time. Next slide. Yeah. Okay. Okay. So we talked about this briefly, but a Lewy body is basically a clump of it's when a normal protein misfolds, and those and its synuclein is the normal protein, and it becomes alpha synuclein. That's the changed form of the protein, and they clump together and become the Lewy body. That next slide. And that big black blotch or brown blotch is an example of what a Lewy body looks like. And then, the next thing I'll talk about is just basically how, like I was saying, it starts in one part of your body, the nerve cells in one part of your body, and then more nerve cells become affected over time. And that's called the Brack hypothesis. And Brack is a German anatomist who basically looked at, people who had passed away, and he looked at nerves in different parts of their body and saw that often the nerves that were affected with Lewy bodies initially were in the nerve cells surrounding the gut or surrounding your olfactory nerves, the nerves that deal with smelling. And then he would notice that, the nerves would then move from around the gut. The abnormal Lewy bodies would, be seen around the nerves around the gut, and then it would go to like another nerve that was close by, and that would affect your brain stem, and then it would see just different levels. So there's like a path that it would go to where more and more nerve cells were being affected, but usually in a very typical pattern. Okay, and this just shows an arrow of how it moves up. So it starts in the brainstem, which is that very bottom orange part, that orange arrow down there. And when it gets to the part of your brainstem that deals with, and it's in the, I believe in the orange green area, in that area, when those nerve cells have been affected, that's when some of those nerve cells deal with paralyzing your body when you're asleep, when you're having dreams. And when those are affected and die, then people start acting out their dreams at night. And then it goes to the top of your brainstem, kind of that pinkish area. And when it's in that area, then it destroys nerve cells that produce dopamine. And when those are destroyed, that's when people start manifesting slowness and stiffness and tremor. But then it doesn't stop there. More nerve cells end up being affected over time, as you can see in the yellow and the white areas. You know, parts of your brain that deal with balance and cognition start becoming affected. And that's my way of saying that it's not just the part of your brain that deals with tremor and slowness. We have meds that, we'll talk about that in a moment. We have meds that treat the tremor and slowness to some degree, but they're not the same meds that are going to, you know, treat acting out your dreams at night or, you know, having cognitive impairment, because those are those are other neurotransmitters that are, you know, that have been affected in those nerves. Okay, next slide. So we briefly talked about this. So what are some of the premotor symptoms of Parkinson's? These are symptoms that people get before they actually start manifesting the motor symptoms of Parkinson's, which is tremor and slowness. So the premotor symptoms, before you manifest symptoms, you know, people don't really know what's going on initially because they don't think, oh, this is a symptom of Parkinson's when they lose their sense of smell or when they have constipation or when they act their dreams out at night. But those are symptoms that occur because Lewy bodies have infected those cells, basically. So those are things that people might notice initially, but not realize are related to Parkinson's. Next slide. And then the motor features, like we talked about, are the symptoms that people have when they go see me or Dr. Anderson and say, something's wrong. My doctor told me to come see you because they're worried about Parkinson's. It's because you've started manifesting tremor, slowness, or stiffness. And these symptoms often can be controlled with medications for a long time, medications that deal with dopamine. Okay, next slide. So when the substantia nigra is a part of your brain that's at the very top of the brainstem, and when, you know, 60 to 80% of those nerve cells in the substantia nigra have been destroyed, that's when people start manifesting the motor symptoms of Parkinson's, of the slowness and stiffness and tremor. And, you know, normally when those nerves are present, they help with coordination of movements and smooth and curated movements. And the substantia nigra communicates with other nerve cells by producing dopamine. Next slide. And so that's just showing you basically where the substantia nigra is, that little pink spot at the bottom on the top of your brainstem. So, you know, dopamine is a very important neurotransmitter in Parkinson's disease because, you know, a lot of the medications that we give people for slowness and stiffness and tremor have something to do with dopamine. That's because, again, the substantia nigra that produces dopamine, those nerve cells have been destroyed. And so sometimes we can help reduce some of those motor symptoms of Parkinson's, of slowness and stiffness and tremor when we give you back some dopamine. And so when people take carbidopa-levodopa, they take that because the levodopa part of carbidopa-levodopa turns into dopamine. The carbidopa part of the carbidopa-levodopa makes it so you don't vomit when you take the levodopa part of the carbidopa-levodopa. Carbidopa-levodopa is also known as Sinemet for people who only know it by its brand name. But there are other meds that deal with dopamine also, like dopamine agonists like ropinirole or pramipexole or rotigotine. Those are all meds that mimic the shape of dopamine. And some people take those medications and get some benefit in their Parkinson's symptoms as well. I won't go into it too much, but we don't use the dopamine agonists as much as we do the carbidopa-levodopa or Sinemet because the dopamine agonists don't work as well and they have more side effects. And then there's entacapone and MAOB inhibitors like rasagiline and selegiline, and they basically are medications that stop the dopamine from being broken down so that it stays in that synaptic cleft longer where, you know, the dopamine is still stimulating a nerve for a longer period of time rather than being broken down and repackaged. So my point is that all of these meds help with slowness, stiffness, and tremor to some degree, but they all have in some way affect dopamine. Next slide. So we're getting to the point of this conversation, which is really like, once we get beyond that phase of, getting pretty good improvement with slowness and stiffness and tremor with the dopamine medications. We start getting to the point in Parkinson's where things are harder to deal with and there are more issues with side effects to meds and things like that. So that's what we call mid-stage Parkinson's. And what happens at that point is that there's further progression of the slowness and the stiffness and tremor. It just keeps on getting worse because you're losing more nerve cells that produce dopamine. And then you can get something called motor fluctuations. We'll talk about that, but basically where the meds stop working and you have to take more and more of them. There's dyskinesia, which is a side effect of the medications. And then some people get dystonia, which is a Parkinson's symptom where your muscles get really tight and you get abnormal posturing of your limb. So let's go to the next slide. So like I said, there's progression of the symptoms that you see in that early stage of Parkinson's. So tremor becomes more intense, maybe it affects more body parts, maybe it occurs more frequently. You become slower and stiffer and more body parts become involved. So maybe it just started on the left side of your body, but over time the right side starts to become involved as well. Although the left side, the initial side, will always be more affected than the other side. Imbalance starts to intensify. People might feel like their feet are getting stuck on the ground or they have difficulty picking their foot up when they walk. And then, we try to treat these, the slowness and stiffness and tremor with more carbidopa, levodopa, or medications that affect dopamine. And that's one way that we deal with it. And then we also start recommending physical therapy for imbalance and falls. Next slide. All right, so in this mid stage, we also see motor fluctuations. So that's when there is suddenly a big change in the way that you move. Like you take your meds, you're walking fine, and then 3 hours later, suddenly you can't move your feet like you could an hour before. And when the meds are working, we call it on time, and when the meds aren't working well, we call it off time. And in the beginning stages, people might have a little bit of off time. Maybe they'll take their meds, one tab of Sinemet or carbidopa, levodopa 3 times per day. And they'll notice a little bit of wearing off if they forget a dose or maybe just like a couple minutes before their next dose is due. In the mid stage, there's a shorter duration that the Sinemet works for. And so you have to start taking it instead of 3 times a day, maybe 4 times a day or 5 times a day. And then as you get really towards the end stage of Parkinson's, you just start wearing off randomly. It doesn't seem to make sense anymore. There probably is some on time, but it's not as apparent when you're on and when you're off. And it doesn't seem like the meds really have as much of an influence on when you're on and when you're off. Next slide. And this just shows you a graph of what you look like when you take the medications with the motor fluctuations, the ons and offs with the medication. And it's showing you in the first 4 years or so, you take your meds, there's a peak in the curve, and then the meds wear off, but you don't really notice a difference on and off. That dark area is where you're off. The gray area at the bottom is where you're off. So you don't really get into that off period. Now the pink area, we're going to talk about this in a little bit, is where you start getting dyskinesia. That's a side effect of the meds where you get involuntary swaying movements. So initially you take the meds, you have a peak dose, no dyskinesia, your meds drop, you don't wear off, you take your next dose, you're doing fine. You feel the same basically all the time. But as you get further along, maybe getting towards that mid stage, you start hitting that off period more often and you start feeling your off periods when your meds drop, right? And then when you take your meds, you start getting dyskinesia at some point. And so at your peak dose, you start getting to that pink area where you take your meds, you get some dyskinesia, then maybe the amount of medication in your blood drops a little bit and you have maybe a couple of good hours where you don't have any dyskinesia, you don't have any side effects, but you're not off either. So the meds are working well. And then you hit that off period. And as you can see, as you get further and further along, that period of time when you feel normal, like the meds are working and you're not having side effects, becomes a much narrower period of time. Okay, next. Yep. And then how do we treat these motor fluctuations? Well, one option is just to take your carbidopa, levodopa more frequently. You just, instead of taking it, like I said, 3 times a day, maybe you take it 5 times a day. Some people even get up to 8 times per day. Maybe you'll try a long-acting form of Sinemet, or of carbidopa-levodopa. So there's an old form of Sinemet that's a long-acting form that wears off inconsistently. So we don't love prescribing that one for the daytime hours. But, it's an option. Sometimes we try it when we're desperate. There's a newer long-acting form called Rytari that wears off less often. It has less of a peak dose, so it doesn't cause as many side effects. But it is wicked expensive, and it might not be covered by your insurance, and it's a little bit more of a challenge to get it for some people. For some people, we give them a medication that extends the duration of effect of the carbidopa-levodopa, like entacapone, or maybe an MAOB inhibitor like rasagiline. And again, those are medications that basically prevent the breakdown of dopamine so that people just are stimulated by the dopamine for a longer period of time. Again, some of those medications are expensive too, so they might not be a great option for some people either. And then there are some other medications that we use far less often, like there's an adenosine antagonist, and that's a medication that kind of works like caffeine. And I'm not really going to go into it because I don't think it's a great medication. And then there's what we call recovery medications, which are meds that basically increase your dopamine in different ways, or act like a dopamine agonist, and they act as if you have more dopamine in your system. And those are Inbrija and Apokine and Kenmobi. And those are different medications that maybe you put something under your tongue and it can get you out of an off period faster. Or Inbrija is a form of levodopa that you inhale and it gets into your blood system faster, because if you inhale it into your lungs, there's blood vessels close to the walls of the lungs, so that it gets in really fast into the blood that way. So there are some options, but all of those medications, again, are newer medications that are very expensive and have their own quirks associated with them. And then finally, for motor fluctuations, we'll talk about this later, but some people get deep brain stimulation, which is a brain surgery that sometimes can reduce the severity of the off periods. And that's it, yeah. And so this is what Inbrija looks like. That's one of the recovery medications that you can inhale into your lungs. Some of the quirks with that one are if you have like any breathing disorders like asthma or COPD, or if you just cough every time you try to inhale it, it might not work well for you. But that's one that a lot of our patients use. That's good. And then another one of the mid-stage issues that a lot of people have to deal with is dyskinesia. That was that side effect that we were talking about that people get when they get to a peak dose of medication. Usually it occurs like within the hour after they take their Sinemet or carbidopa-levodopa. Although some people can have dyskinesia that occurs as they take the meds and as they wear off of their medications. So that's another way that it can present. So dyskinesia is an irregular dance-like movement. It's just kind of a swing movement, and it can affect your whole body. It can affect just a leg or just an arm. Some people get it in their mouth. I've had some people with their eyes moving involuntarily. And that's basically it. Yeah. Next slide. I just put up a picture of Michael J. Fox because whenever I tell people about dyskinesia, I usually say, for example, Michael J. Fox is someone who has a history of dyskinesia. And if you know what he looks like, you probably have a sense of him kind of wiggling around a lot. Teresa, can you actually show that? No, it's a video. I don't know if you're going to be able to show it. Don't hit that. Because I sent you the slides, you might not be able to do it. Do you know? This is a woman who has I won't be able to show you guys this, unfortunately, because I can't show you my slides for some reason.
Yeah, I don't know. When I click it, it comes up to a YouTube. It says, "Are you sure you want to leave YouTube?" And I'm not trying to leave it. I want to see it, right?
Yeah. You want to see if it works?
If it, no, it brings up his website, but no video.
Okay. Yeah. Okay. Well, we're going to move on. I'm not going to show you what she looks like with dyskinesia, unfortunately.
You can kind of tell by her posture too.
Yeah, she's kind of, her whole body was just wiggling around. It's not always that severe though. So how do we deal with dyskinesia? Well, you know, one of the first things we do is just reduce the dose of Sinemet because it's a side effect of taking the Sinemet. So if we just give you a lower dose, then sometimes it takes care of the dyskinesia. But, you know, um, you give someone a lower dose of of Sinemet, then they're going to have more slowness and stiffness and tremor because that's what the Sinemet is treating. So sometimes the way we get around that is to give you a lower dose of Sinemet, but give it to you more frequently. And, that can sometimes get around the dyskinesia and the off periods. Sometimes we'll give you a long-acting form of medication like Rytary, which is the long-acting carbidopa-levodopa, because that one doesn't have as high of a dose that goes into your system at once. So you don't have as many side effects because the peak of the medication in your blood is not as high. Or sometimes I prescribe amantadine, which is a medication that's an old flu medication that incidentally was found to work well for dyskinesia. And then finally, if the dyskinesia is really bad, sometimes we do deep brain stimulation surgery, which is a brain surgery that we'll talk about later. I guess we'll talk about it now. So deep brain stimulation surgery is where you get thin metal wires that are implanted deep into your brain and a part of your brain where, we believe that signals are interfering with your ability to move normally. And when you're stimulated with electricity in those regions, then that can help reduce dyskinesia and tremor. The electrodes in your brain are connected to a thin metal wire that goes under your scalp and then is attached under your chest wall to a battery basically, but it looks like a pacemaker would. And sometimes that battery has to be changed every few years, depending on what kind of battery you get in there. But anyway, when you get deep brain stimulation, it can help reduce tremor. It can help reduce dyskinesia. It can make those off periods less severe. It can help reduce dystonia, which we'll talk about later. That's just involuntary cramping movements of your muscles. But DBS is not for everyone because it can worsen balance issues and it can worsen cognitive impairment. So if you have, if you've advanced too far with your Parkinson's, you don't want to wait too long because you might not be a good candidate at some point, because everyone at some point starts getting imbalance and cognitive impairment with Parkinson's if you live long enough. And so you kind of want to consider deep brain stimulation sooner rather than later. And that's just a picture that I kind of screwed with, but that shows the electrodes in the brain connected to the battery in the chest. They call it a pulse generator. Dystonia is another one of those mid-stage Parkinson's symptoms. It's the uncontrolled pulling of muscles that leads to an abnormal posture. In my patients, the most common way that it presents is toe clenching, where the toes flex or extend and they're very uncomfortable and sometimes make it difficult to walk. Sometimes it'll be abnormal arm posturing or neck posturing, but that's less common. And often dystonia will occur when patients wear off of carbidopa-levodopa, but sometimes that's another one where it occurs when people take their meds and then as they wear off of their meds as well. And that's just a picture of what dystonia can look like. You see the foot on the patient's right foot, which is on the left side of the screen. The toes are clenched, but on the right side of the screen, his left foot, one of the toes is extended. And so how do we treat dystonia? Well, like I said, sometimes it responds to carbidopa-levodopa, Sinemet, but not always. Sometimes it responds to deep brain stimulation, but that's kind of an extreme measure and not everyone wants that. Often I'll treat that symptom with Botox, which is, people know about Botox from cosmetic purposes where, you get it injected into your skin to make you have less wrinkles. Actually, go on to the next slide. I think it has a picture of Botox or something. Yeah. So Botox is a toxin that's produced by bacteria. But we found ways to produce amounts of it that we can inject into people in less harmful ways. In the past, people used to accidentally, and I guess they still do, accidentally ingest botulinum toxin by having improperly canned foods, and they would eat like improperly canned beans or something like that, and this bacteria would get in and produce this toxin in the canned food, and then you would ingest it and your whole body would become flaccid and weak. It would weaken the muscles. But if you inject very small amounts of it into very focal areas, it can help reduce, cramping because it weakens the muscles. Now, it only lasts for about 3 months. And you have to come back every 3 months to get the procedure done again. It doesn't, in large amounts, like I said, it can be deadly. People can stop breathing, but we don't give you anywhere near that amount. And it's in a very focal area, especially if it's in the foot. People usually don't have any side effects. That's it. We're talking about, some of the motor features of Parkinson's, like how does it affect your ability to move? But, there's also progression of what we call non-motor features of Parkinson's, in addition to the changes in the way your body moves. So, for example, mid-stage Parkinson's can be associated with progression of depression or anxiety, or apathy, which is where you feel like, I don't care, People can start getting a quiet voice. That's called hypophonia. Some people start having difficulty swallowing. That's called dysphagia. Or constipation can be a real problem for a lot of people. Some people get something called orthostatic hypotension, which is where your blood pressure drops when you stand up. And the converse can be true, where your blood pressure gets really, really elevated when you're laying flat. And that one's a tough one to deal with because the Parkinson's meds can worsen those symptoms. Some people get urinary urge incontinence, where they suddenly have to book it for the bathroom and then have accidents on the way there. And that's made worse by the fact that people start having difficulty walking. Some people have insomnia, and some people drool. This is not a complete list of what can happen, but these are just some of the bigger things that I've run into. Next slide. So how do we treat the non-motor symptoms? Well, the medications that we use for the motor symptoms don't really have an effect on the non-motor symptoms. So the Sinemet, the carbidopa-levodopa, entacapone, rasagiline, those meds have no effect for the most part on these other symptoms. And so we kind of pick apart each symptom and treat it separately. So, you have a mood issue, you're given antidepressants, right? Often I give people sertraline, Zoloft, or Wellbutrin, also called bupropion, and then recommend referral to a mental health nurse or a support group. If you're having voice changes, then I usually recommend speech therapy. If you have difficulty swallowing, I usually order a swallow study to make sure there isn't a constriction. And then I refer you to speech therapy to address, tell you how to swallow more normally. If you have constipation, we go over recommendations about diet changes and drinking more fluids and exercising, but also, what meds do we use? And it's usually Miralax is usually top on the list for meds that we use for constipation. But if that's not working, you just go through everything over the counter and find whatever combination works for you. Next slide. If you're having orthostatic hypotension, where you feel like you're going to pass out when you stand up, sometimes you have to reduce the Parkinson's meds. Definitely, if you have blood pressure meds, you should be trying to get off most of those. Sometimes people wear compression hose, although that can be a real challenge because it's hard to get them on, and people with Parkinson's don't move well. More fluids, more salt. I'm like the only doctor who will tell you to eat more salt, so have a lot of potato chips. And then sometimes we have to give you medications to increase your blood pressure, like Mitidrine or fludrocortisone. And then if you have urinary incontinence, there are a few medications for that. I don't love oxybutynin. That's an old one that can worsen cognitive impairment, but it's cheap and that helps reduce bladder spasms. The gentler meds are sulfenacin and tolterodine and Myrbetriq, although Myrbetriq is often very expensive. Sometimes you can be referred to urology and get Botox injections. For sleep issues, You know, there's always sleep hygiene, just making sure that you're doing all the right things in terms of, you know, not looking at a screen before you go to sleep at night, and, you know, not drinking too much water before you go to sleep. But if those don't work, we often do melatonin or trazodone or mirtazapine as sleep aids. If you're drooling, sometimes I Botox the parotid glands and the sublingual glands. I don't like to give medications to reduce drooling because a lot of the meds that reduce drooling cause hallucinations and confusion. Next slide. All right, and then we'll talk about advanced disease briefly. And let's go to the next slide. Really, imbalance and cognitive impairment become the biggest issues with advanced disease. And with imbalance, people have a slow progression over time from, you know, the early stages, you know, onward. There's always a little bit of imbalance, but that just becomes a bigger and bigger issue. And some of the things that people notice include obviously shuffling, where you're not picking your feet up when you walk. A lot of people have difficulty walking backwards, and they're more likely to fall if they walk backwards. If they're freezing, then they have someone just wrote that the slides are not changing. Do you guys see a slide that says imbalance on it? Okay. Yes. Okay. Cool. Awesome. All right. So some people freeze and they have difficulty initiating their gait, where their feet get stuck and they try to lift their foot up to walk forward and it just sticks to the ground. And that gets worse when you're trying to initiate walking, but also walking through doorways. Some people have festination, which is where they can't stop going forward and their whole body seems to be toppling. The top part seems to be toppling ahead of their feet, and they can't stop themselves from going forward. And then there's just a lot of falls. Next slide. And this one, sadly, I won't be able to show you this either, but this basically was a video where a guy is trying to walk, his feet get glued to the ground, especially as he's trying to turn. And you know what it is. It's when you do like very small stutter steps where you just can't lift your feet up and it doesn't seem to go anywhere and you can barely move. Let's go to the next slide. So how do you treat imbalance? Well, you know, you do try to optimize the carbidopa-levodopa and make sure there isn't wearing off. But in the majority of my patients, when they get to advanced disease, even when they're on what seems like the optimal medication regimen, they still freeze and wear off all the time. And there really isn't a great option other than physical therapy and exercise, you know. And it's, you know, if you haven't had a walker or a cane by this time, usually by end stage, you definitely have a walker, a cane, maybe a wheelchair if it gets really bad. Next one. And cognitive impairment becomes a real problem too. You know, even in the very beginning of Parkinson's, where people have just the beginning stages of the motor features of tremor and slowness, and they don't have much else. Studies have shown that there's still just a little bit of cognitive impairment even at that point, and it just accumulates over time. People will have short-term recall issues, difficulty focusing, difficulty performing multi-step activities like, you know, following a recipe or managing medications or managing finances. And a lot of people say that they know what they want to say, but it takes like several seconds longer to put all their thoughts together and spit out the information that they're trying to say. And people can have psychosis. And we'll talk about what that is, I think, on the next slide. Oh, maybe not. Let me tell you about it. Psychosis basically is where you can have hallucinations and or delusions. Hallucinations and delusions are basically where you have, you know, hallucinations usually are visual hallucinations. It's where you see things that aren't there. Actually, go to the next slide. I just want to see if I actually don't remember. Can you go to the next one, Teresa? Oh, okay. We'll talk about it now since I'm there. So visual hallucinations are the most common thing. that people have. And sometimes it's something minor, like you just have like a shadow in the corner of your vision, or you feel like someone's in the room and then you turn around and there's no one there. And if that's what you're experiencing, usually we ignore it because it's not going to hurt you, and people are usually aware of what's going on. Occasionally people will see like a cat in the room that's not actually there, and they'll know that it's not real and they'll be fine with it. But sometimes it gets to be really concerning, like you see a whole family in the room and they won't leave you alone, or like someone you don't like is trying to threaten you or something like that. That's more rare. And when that happens, we do try to treat it. People can also get delusions. Delusions are where you have like a fixed false belief. And I gave an example of the FBI is out to get you. But I've had a patient who thought his wife was trying to poison him all the time, or people who thought that their loved ones were cheating on them, things like that. So go back one slide, Teresa. So how do you treat cognitive impairment? Go forward one slide. With cognitive, go back to the one where it's treatment of cognitive impairment. Yeah. I don't know. Seems like that slide is mad at us. There's something in between that and the psychosis slide. Yeah. All right. How do we manage cognitive impairment? Well, the first treatment that we use if we're going for medications are cholinesterase inhibitors. And the one that I use the most is donepezil or Aricept. And some people can't tolerate donepezil because of loose bowel movements. If that happens, then I do the patch, which is called Exelon. It's very similar, but you wear a patch and it has fewer gastrointestinal side effects. And then sometimes I put people on Namenda or Memantine. And I think it doesn't work quite as well as the cholinesterase inhibitors, but it's an option for people who cannot tolerate the cholinesterase inhibitors, or sometimes I do both at the same time. Also, there have been studies showing that exercise does help with cognitive impairment. So no matter what stage you're at, you should be exercising. And then all the usual things, having a healthy diet, socializing, managing mood issues, because those will all feed into cognitive impairment. And a lot of the issues with cognitive impairment need to be addressed more with, safety measures than with medications, because we can't stop the progression of cognitive impairment. The medications I listed here, they don't cure anything. They don't slow down the rate of decline. They just make some people a little bit more focused. And sometimes they work and sometimes they don't. So a lot of the treatment for cognitive impairment ends up being, making sure that you have, someone to help organize your medications, or make sure you don't drive and someone is giving you rides somewhere. And maybe that's, having a family member help you out, or moving in with a family member, or maybe it means moving to assisted living or something like that. Or hiring someone to come into the house to help out. Okay, and let's skip to 2 slides ahead of this to talk about treatment of psychosis. And how do you treat psychosis, which is the hallucinations and delusions and things like that? Well, we don't treat the symptoms if they're not bothersome. If they are bothersome, then we start reducing some of the medications that you're taking, because just about every one of the medications that I prescribe for Parkinson's will worsen hallucinations and delusions. So, those meds that help at one point start becoming a hindrance at another point as you progress with Parkinson's. And so the first ones that I stop are usually like amantadine and entacapone and rasagiline and ropinirole and oxybutynin and clonazepam. Those are all meds that can contribute. And then if that doesn't do it, then sometimes I reduce the dose of the carbidopa-levodopa, which also contributes somewhat. And then if that doesn't work, then sometimes I start donepezil, that memory medication I talked about. And sometimes that one helps a little bit with psychosis. And if that doesn't work, then I start giving people antipsychotics. The most common one I prescribe is called quetiapine. It's old, it's a little sedating, but some people can tolerate it. And if that's not an option, then there's a newer one called Nuplazid that's less sedating, but more expensive. So it's usually my second line option. But quetiapine is good if your hallucinations are mostly at night, then it'll help you go to sleep. Okay, next slide. So basically, in the end, like I was saying, the most important thing when you get to this end stage is making sure that you have the assistance that you need. Sometimes we do home health referrals where we have physical therapy, check you out at home and make sure that your house is as safe as possible. Sometimes we have a social worker come by and just talk about your options if you're not safe at home. It's good to have a caregiver in the home with you or to consider assisted living if you can't find a way to manage at home. And then, I always like to talk to my patients at some point about, do you have a trust? Do you have a will? Does your trust or will have a power of attorney or an advance directive? A power of attorney is where you make sure that you have named someone who will be able to take care of your finances for you or make, financial decisions for you if you don't have the capacity to do so yourself. Or an advance directive is to make sure that you've stated in words, how you want to be treated if you are found down on the ground. Do you want CPR? Do you want someone to go full bore and, intubate you and be on a respirator or get a feeding tube? There are choices in between that. You don't have to go all the way and you don't have to say absolutely nothing, but those are things that you want to think about before you get to that situation, because a lot of people don't want to be on a respirator for the rest of their lives. And if you don't have a close family member who knows what you want, then you're kind of stuck. And so are the caregivers saying, okay, I guess we do everything, so it's important to have these things down on paper. I also like to say, if you have family members that you trust and you're getting to the point where you're starting to not make the best decisions for yourself, financially, you want to make sure that you have, your spouse or a kid on your financial accounts with you if you trust them, hopefully. Because if you do start making stupid decisions with your money and you're getting swindled, it's hard. You can't tell the bank to not pay, you can't tell the bank to stop the payment on that if there isn't someone else on the account. Even if you have a power of attorney, you can be in a difficult position where you have to go through the court system, and it takes a lot of time and a lot of money to actually, make the power of attorney work if, you don't already have someone else on the financial account with you able to make an immediate decision. I hope that makes sense. Anyway, I think that's one of the most important things to think about in this whole process. So next slide. That was a lot of stuff. Hopefully not very
stuff.
Yeah, probably not all happy stuff that I talked about, but Teresa, were there a bunch of questions that I need to answer?
Yeah, so we do. We have some questions. Let's see, I'm getting a little background noise while I talk. Are you guys okay?
Yeah, I can hear you fine.
Yeah, so the first one was the links that I was unable to run on those videos. Were those, I might be able to get them off the original from you. I might have you forward them to me again, and then I'll include them in the email next week when I send out a video link to the event, and then they can watch the people with the dyskinesia or the freezing of gait, things like that.
Okay, that sounds good.
So I'll give that a try. But one of the questions was, does everyone eventually progress into mid or late stage symptoms? Is the rate of progression unique to each individual?
Yeah, I think if you live long enough, you will eventually get to advanced stage Parkinson's, yes. But not everyone does. I mean, as I like to say, you could get hit by a car. I can't predict what's going to happen to you. You could die of a heart attack. But if you do live long enough and something else doesn't get you, eventually Parkinson's will affect cognition and imbalance to a significant degree. And yes, you will be advanced stage. And the degree to which you advance is different. I mean, the rate at which you advance is different for everyone. A perfect example is Michael J. Fox, who got diagnosed in his 20s or 30s. He's still going at this point. I don't know how many years later, but 20 plus years later, maybe close to 30. Whereas if you get diagnosed when you're 82 or, older, you're going to progress faster. And also if you have tremor predominant Parkinson's, you tend to go at a slower rate than people who are more slow and stiff generally. But, there are other things that can influence it, and you don't know where you're going to end up on that spectrum until you live your life.
Okay, good. Another question is, briefly, can you talk about the hereditary implications of Parkinson's? One person in particular, her father and her grandfather both have Parkinson's.
Yeah, I mean, your risk does increase if you have a family history. Now, I was taught to say like it doubles if you have a family history of Parkinson's. So, but the average risk for Parkinson's is about 1 to 2% of the population after the age of 65. If you have a family member with Parkinson's, a close family member, then that risk doubles. So what is it, like 2 to 4% risk, something like that. So it's still a relatively low risk, but there are some genes that increase your risk more than others. The question is, do you get tested? Do you get the genetic testing? And in general, we don't recommend that because it's, you know, getting a gene that increases your risk generally does not, I mean, there's still a good chance you won't get Parkinson's, even if you have a gene that increases your risk. And we don't have medications or anything that definitively stop or slow down Parkinson's. So until we figure out a cure or something that slows it down, and I think that's answering someone else's question, what's the point of knowing sooner rather than later, because you'll just scare the crap out of yourself, and it might not change what happens. I mean, it won't change what happens, but there's still a good chance you won't get it, right? So anyway, is there anything that slows down the rate of decline of Parkinson's? Not that we know of at this point. Now, maybe exercise. There are some studies that suggest that maybe exercise, and there's not one particular exercise that slows it down. I mean, it's anything that gets your body moving. And the recommendation for exercise is 30 minutes 5 times a week of moderate aerobic activity, and 10 minutes twice a week of strength training, and 10 minutes twice a week of stretching. And it can be anything that fits that criteria. And there's one med that is touted as possibly slowing down the rate of decline of Parkinson's, but I think most of us don't think it actually works, and the data behind it is not great. And that medication is called rasagiline. It can be expensive, and I'm not really super enthusiastic about it.
Wow, real cool. What about the average age of diagnosis with Parkinson's?
I've seen the average age listed in the, I think, early to mid 60s, but I'll say the majority of patients that I diagnose tend to be older, and but there are some people that I think bring down that average. Like I have a few patients in their 20s, a few in their 30s and 40s, and they bring down the average, but I think the majority I end up seeing are in their like late 60s or early 70s.
Okay, real good. There was one that we skipped over, if we can take time to do it. And I think you kind of touched on a little bit. This person is asking, if the patient cannot tolerate any of the medications, what is the best treatment?
Well, that's a good question, because some people can't tolerate it because they just want to vomit every time they take them, or they get orthostatic hypotension where their blood pressure drops every time they take the medication. And so it kind of depends on the patient. Now, for some patients, we will do deep brain stimulation surgery, which is where you get the metal implanted into your brain, and you're stimulated with electricity in your brain. And that's an option for some people, but that's a minority, because a lot of people already have cognitive impairment and balance issues, and the surgery is not good for those people. So it just depends on what your individual profile is like.
Yeah. Agree. What do you know about stem cell treatments? Where are we at with that?
I still feel like we haven't gotten that far with stem cell. The last time I looked it up which was a couple of years ago. The data behind it still was not that great. And like the studies I had seen, basically people who got stem cells after they passed away, they would look at their brain they would autopsy the brain and find that those stem cells then became infected over time with the Lewy bodies and the pathogens or whatever from Parkinson's. And so you still will get affected. And those patients who did get the stem cells, a good chunk of them ended up having, if they had dyskinesia, that wiggling movement, it became harder to control with medications after they got the stem cells placed.
Yeah. I know we're running short on time. I just want to do another maybe 1 or 2 questions. One of them talks about environmental risk factors.
I mean, I get, pesticides, head trauma, I've seen some things about milk, but that one, just 1 or 2 studies. I think everything's been studied and possibly contributing. Hereditary factors. We don't know though, for the Agent Orange, if anyone has Agent Orange exposure, go to the VA, because you'll get a lot of your healthcare covered. because they know that there's a clear correlation between Parkinson's and Agent Orange. So, there are a lot of different things that could possibly increase your risk, but we don't know definitively what does it for the majority of people.
Okay. Let's just do one last one really quick, and then I'm going to need to switch to our next guest speaker. And I really appreciate all these questions because they're really good. Oh, which one do I go with? I don't know. Can you see the questions there too?
Let's see.
You mentioned Lewy bodies in the GI system. Are there any symptoms at all in the GI system if Lewy bodies have not spread to the other parts of your body?
Oh, no. It would just be constipation. And even if we knew that the constipation was related to Lewy bodies, what can we do about it? We still don't know how to stop it,
Right. And on focus ultrasound, that's pretty much, I know it's being offered at our university here in Portland. It's not something that we've done at our sister hospital, Swedish, up in Seattle. Focus ultrasound's been largely used for people with essential tremors. What can you say about it being used for Parkinson's?
I think it's still being used sparingly, and it's still preferred that people get deep brain stimulation over the focus ultrasound because focus ultrasound is a one and done procedure and you can't really adjust it, whereas we often have to adjust deep brain stimulators over time to get like the perfect, degree of stimulation and location in the brain that we're stimulating. You can't adjust focused ultrasound. And so that tends to be more for people who just are like, there's no way I'm going to get a surgical intervention or have hardware implanted into my brain or have other contraindications to getting, deep brain stimulation. But it's still not one that is preferred over, for the most part, over deep brain stimulation.
Excellent.